Good evening, everyone. My name's Romy Basine. I'm an endocrinologist over with Columbus Endocrinology. Okay, it's nice to talk to a bare room. I've not done that before, so pardon me if I'm a little disengaged here. But anyways, our topic, that I'm going to talk about today is osteoporosis. Just titled it as the bare bones and a little more. So basically all the stuff that I guess all of us should know and I guess put into practice. So hopefully we'll learn something with this. So just moving on, I think.
We might need you 1 second.
Okay. No? Sorry, technical glitch. These ones. Oh, these. My bad.
That's okay.
All right. Okay. Yeah, now we're going the right direction. Sorry about that, guys. See, so just to start, just the objectives as to what we'll be saying and what we will be talking about. We're hoping by the end of this that everybody will know and understand who should be evaluated for osteoporosis, who should be treated for osteoporosis, what are the treatments available, how should you follow these patients, and just some basic little tidbits on interpretation of DEXA. As I'll try to span the whole gamut of osteoporosis within about a half hour to 45 minutes. So just bear with me here. As you all know, the WHO classification for postmenopausal osteoporosis, normal is a bone density of -1 or higher. Low bone mass would be osteopenia, which would be between -1 and -2.5. And then osteoporosis is if the bone density is below -2.5. Severe osteoporosis would be if it's below -2.5 with an overt fracture, or sometimes below -3. So what is osteoporosis? Basically, it's defined as low bone mass. There's microarchitectural disruptions. You get little holes in the bone. There's increased skeletal fragility because of this. And because of all of these changes, you get less strength in the bones and increased risk of fractures. Basically, some of the bricks have been removed from the home, so things are more likely to fall. And that's just the kind of the schema which everybody knows. If you look on the left side, I guess, yeah, your left side, there's the healthy bone. And then if you look on the right side, there's the osteoporotic bone where there's been disruptions in the lamellar architecture there. And you see kind of like holes in the bone, if you want to think of it like that. And that leads to structural weakness, which in turn causes the osteoporosis. So why are we concerned about osteoporosis? Well, as we all know, it's a major health problem. There's over 10 million Americans who have osteoporosis. Additionally, about 43 million have low bone mass or osteopenia. More than 2 million fractures every year in the US alone. And that's more than 70% of these fractures occur in women. So again, more than 20% of postmenopausal women have prevalent vertebral fractures at any given time. And the most common osteoporotic fractures are, of course, vertebral fractures, which are a hallmark of the disease. And those indicate a high risk of future fractures. That's an important point to note because sometimes you'll see a bone density that says osteopenia, and yet you see that there's been compression fractures. So always keep in mind that those people would likely need treatment. But we'll get more into that as we go along. So in addition, majority of vertebral fractures are actually asymptomatic, even though some of them may cause difficulty breathing, or they may cause height loss, or some of them may cause some pain. So in 2005, for example, there were 2 million osteoporotic fractures in the US. About 40% of people who experience a hip fracture are unable to walk independently at 1 year. and 60% require assistance with at least one activity of living. Hip fractures account for a large portion of the morbidity and mortality that is associated with osteoporotic fractures. 21 to 30% of these patients end up dying within a year of their fracture. So these are serious things. Osteoporosis is usually asymptomatic until a fracture occurs. And so preventing the osteoporotic fractures is the major goal of an osteoporotic screening strategy and then treatment strategy. So what are some of these risk factors? Age is an independent risk factor. That risk increases progressively as we get older, with a doubling of every 5 to 10 years, you get a doubling of the risk of osteoporotic fractures in women. So nearly a quarter of women over 65 have osteoporosis. Over the age of 80, almost a third of women have had osteoporosis. So as you can see, it's a serious problem. You've got more than half of women 65 or older who have osteopenia. And even though fracture risk is highest in osteoporotic women, the overall majority of fractures end up occurring in osteopenia because there are more women in that category. So who do we screen? So this is a case of a patient, Jane M., who is a 57-year-old female, postmenopausal, no history of fractures. Her family history is significant for a mother who had osteoporosis and a hip fracture. She has a history herself of severe asthma and is on inhaled steroids as well as on albuterol. She has needed prednisone treatment with prolonged tapers for exacerbations of her asthma, sometimes needing them for up to 3 to 4 months every year, especially over the last 10 years. So the question is, should Jane be screened with a bone density test? So this is the U.S. Preventive Services Task Force recommendations. After age 50, the prevalence of osteoporosis is greater in women than in men, of course, 15.4% versus 4.3% respectively. Prevalence varies by race and ethnicity. It's the highest in Mexican Americans and then in non-Hispanic white adults, lowest in non-Hispanic black adults. Prevalence increases dramatically with age, from 5.1% in adults aged 50 to 59 to, here it says 26.2% over 80. So who do you screen? Well, you screen all women who are 65 years of age or older. You can screen, you also screen postmenopausal women who are younger than 65 and have clinical risk factors for fracture. And these clinical risk factors include advancing age, previous fractures, low body weight, previous hip fracture, glucocorticoid use, smoking, alcohol use of more than 3 drinks a day, and then secondary osteoporosis, which can result in, which can be caused by premature menopause, malabsorption, inflammatory bowel disease, other chronic issues like liver disease and so on. And do you screen men? Well, U.S. Preventive Services Task Force says there's not much evidence, so they don't recommend that. And the Endocrine Society, the National Osteoporosis Foundation, and the ACP all say that we should screen men who are 70 or older. 50 to 69-year-old men per the Endocrine Society should be screened if they have other causes for bone loss, for example, or other criteria suggesting bone loss, like X-ray criteria, where if you read a regular X-ray and they say, well, it looks like there's osteopenia on an X-ray, that probably means they likely have osteoporosis. And if they have a history of low trauma fractures, and we'll get into what low trauma is afterwards, if they have lost more than 1.5 inches in height, or if they have other risk factors for fracture, which are again secondary risk factors, like long-term steroid use, or they've been treated with androgen blocking therapy for prostate cancer, or they have hypogonadism, or they have hyperparathyroidism or other intestinal disorders. So going back to that question, should we screen Jane? So she's postmenopausal. she's got 2 risk factors. She's got a family history of hip fracture in her mother, and she has a history of prolonged treatment with steroids, with prednisone. So you would say, yes, we would screen her. She'd have a DEXA scan to evaluate her bone density. So again, this is not a postmenopausal woman, but you always have to keep risk factors in mind. All right. So in general, we've been not doing so well in testing bone densities overall. Per the HEDIS website, only about 72% of Medicare HMO and 79% of Medicare PPO patients have been screened as of 2017. If you look at women who had a fracture, even lower screening rates or who've had bone densities about 50% or less, according to in 2018. So there's a serious problem here. We can all do better in terms of screening, and that way we pick them up and we treat them before they have fractures. So then the question is, if you do pick one up, well, how do you treat? What happens next? So here's case 2, which is a 65-year-old white female who had a left ankle fracture. She basically fell while walking on the pavement. Her foot got caught in a drain hole. She fell really hard on her left side. She twisted her ankle in the process. So the x-rays show a non-displaced left lateral malleolus fracture. She was then treated successfully with a stabilizing boot. Then she saw her primary doctor, who said, okay, let's get a DEXA. And that DEXA scan shows a bone density at the lumbar spine is low, with osteopenia at L1 to L4 with a T-score of minus 1.9, and osteopenia at the femoral neck with a T-score minus 2.0. So questions are, does she have osteoporosis? Or does she have fracture with osteopenia? Would she benefit from treatment? What other tools can we use to help us in this regard? Okay, so who do we treat? Now we treat postmenopausal women who've had a history of fragility fracture, and I'm going to get into fragility fracture in just a minute, or they have osteoporosis with a T-score less than minus 2.5, or especially women who've had a recent fracture, including hip fractures, must be thought of because they're high risk for a second fracture. So high-risk postmenopausal women also should be screened, whose T-scores between minus 1 and minus 2.5. And in these women, the way we calculate, they should be treated. The way we calculate whether they should get treatment is using the FRAC score, which is the fracture risk assessment tool designed by the WHO. We'll get into that a little bit more, but the threshold that they use is a 10-year probability of hip fracture or combined major osteoporotic fracture of more than 3 for hip fracture or more than 20% for major osteoporotic fracture. This is the 10-year risk. So doing this is relatively easy in a sense because it's all set up for you in the computer. If you web search for FRACs, you'll find the website. You'll see they have the WHO risk assessment tool shows up, and what you want to do is select US because it's broken down by country. So the risks are assigned based on country statistics, and so basically you enter their data like their age, their weight, height, whether they had a fracture, all kinds of risk factors like smoking, glucocorticoid use, any secondary osteoporosis, alcohol use, and then you select DEXA on the thing, and then you hit calculate, and it gives you a number. So that number again is if it's more than 3% for hip fractures, you treat them. If it's more than 20% for major osteoporotic fractures, you treat them. Okay, so we said we'd talk a little bit about fragility fractures. So how do you define a fragility fracture? Because this will help to define whether you should treat some people or not, especially those who have minus 1 to minus 2.5 bone density, as well as other people. So fragility fractures are defined as a fracture falling from a fall which is standing height or less with no trauma. So somebody just gets up from a chair, they tumble down and they break a hip, that's a fragility fracture. And common sites of fragility fracture include the spine, the hip, the wrist, and then also humerus, ribs, and pelvis can be included in that. What's not a fragility fracture is, for example, skull fractures, hands, feet, ankles, but not the radius, which could be considered one. Cervical spine can also be sometimes not classified as a fragility fracture. So we go back to question 2, the patient number 2. So does she have osteoporosis or does she have osteopenia with fracture? So, well, her bone density suggested was osteopenia, and now she has osteopenia with fracture. Now, this fracture is in her ankle, not her spine, and not her hip or radius, so she doesn't have a fragility fracture. If she had those, she would be treated effectively like she had osteoporosis, which means you would treat her. Now that she doesn't, would she benefit from treatment? So to figure this out, the FRAC score would be useful. And sorry, my phone just turns on itself. Excuse me. The joys of technology, excuse me. So, all right, so would she benefit from treatment? And then so you do the FRAC score, and it turns out if she has a FRAC score of 20% or more, or hip fracture risk of 3% or more, then you would treat her. And does she have that risk? Okay. Where do we go here? Should I go backwards? Yeah, so I didn't actually calculate out the number, but it doesn't quite work out that way. But anyway, she ended up having osteopenia, and the FRAC score didn't meet the requirements, so you would not treat her. So what kind of test would you do if you wanted to, if somebody came in with osteoporosis? Now, because you can get secondary osteoporosis, even in apparently healthy postmenopausal women, lab testing should be done, at least basic labs should be done. And those include things like CBC, which could help screen for certain types of cancer, for example, comprehensive metabolic panel, which includes calcium, albumin, creatinine, which could screen out hypercalcemia due to hyperparathyroidism or other reasons. 25-hydroxy vitamin D, because low vitamin D could be a cause of low bone density. TSH, because hyperthyroidism can result in low bone density, and a 24-hour urine collection for calcium and creatinine, especially if they have high calcium in their blood. So what kind of test do? You do a bone density of their axial/skeletal central skeleton, which means the spine and hips, and sometimes you do the distal 1/3 radius, especially if they have high calcium and hyperparathyroidism. The vertebral fracture analysis, which is the VFA, it can be done if you're over 70 years old and you're female, or if the patient's over 80 years old and is a man, and the score is greater than, the T-score is more negative than -1, or they have a height loss or vertebral fracture history. VFA is an interesting thing because a lot of times the insurance may not cover it, because a lot of them have it written in their guidelines that there's no indication for VFA. So just to keep that in mind. So here's case 3 then. So we have a 67-year-old female who has hypertension, who presents with bone density showing L1 to L4 T-score of -3. And then there's an absolute bone density written there. The femoral neck T-score is -2.8. She has seen her primary doctor, who suggested, hey, let's get you on Fosamax, which is a good drug for osteoporosis. What did she decide? Well, she read it on the internet that, taking calcium and vitamin D just works fine, and she doesn't want any treatment. So she had an argument with the doc, and so left him and decided to come to see you. So what do we do now? What can you actually tell her about calcium and vitamin D, or lifestyle in general? So treatments include lifestyle changes that can include calcium and vitamin D intake, 1,200 milligrams of calcium a day and 800 to 1,000 units of vitamin D a day. Exercise up to 30 minutes 3 times a week, especially weight-bearing exercise, which could include walking. So how well do these things work? Well, in a meta-analysis of 10 trials, exercise reduced overall incidence of fractures, but the vertebral fractures were not reduced in a statistically significant fashion. So that could be because a lot of these trials had relatively few patients in their vertebral fracture trials. Um, I'll add one more. Okay. Anyways, so they can stop smoking, because smoking accelerates bone loss. And then in one study, they saw that if they smoked about 1 pack a day for most of their life, you have a 5 to 10% reduction in bone density. So stopping smoking may help reverse a little bit of the bone density loss or slow it down. You could decrease your intake of alcohol, and the data shows that people who are alcoholics, who have very heavy alcohol use, that tends to predispose to osteoporosis and falls. People who have moderate alcohol use, the data is more mixed. Some studies show the bone density actually increases, some show decreases, so it's very variable. And a study done in looking at the fall risk showed that people who consume more than 14 drinks a week had a higher fall risk, so consequently likely had a higher risk of getting fractures. So what about calcium and vitamin D? So there's been a number of studies that have shown some beneficial effect of calcium or calcium D or on bone density, but the data on fracture rates are more variable. And then some trials show there's a reduction in fracture, then larger trials didn't show that risk reduction with calcium plus vitamin D. So the data is all over the map of all of these trials on calcium and vitamin D. The Women's Health Initiative subgroup analysis is one that showed that giving calcium and vitamin D causes reduced fracture incidence in those individuals who were most compliant. Now all our patients are compliant, so of course everybody's going to do this. No. Anyway, so the variable results basically are because there's so many different populations studied in different study designs, different community settings. So it puts a lot of difficulty in terms of analyzing this data, but essentially you've got very little effect of calcium and vitamin D is the bottom line. And then some studies show some reduction in fracture with calcium and calcium with D, but not with vitamin D alone. Relative reduction is relatively modest in terms of hip fracture as well. So back to our patient. So in our patient, I guess they should take calcium, they should take vitamin D, but because they have osteoporosis, they will need additional therapy. And so you will gently break that to her and hope she doesn't go looking for her next PCP. All right. Okay, so how do we actually treat osteoporosis? There's many different ways of treating. Essentially, this slide just has some of the different agents that we use. We use bisphosphonates like, oops, is there a pointer on this thing?
There is not. If you want to point, if you use the mouse, you can move the arrow.
Yes, good thing. All right, so you have bisphosphonates like alendronate, which is Fosamax, ibandronate or Boniva, risedronate, which is Actonel, and zoledronic acid like Reclast. So you could use those alendronates once a week at 70 milligrams a week. Ibandronate can be used once a month. Let's see, Actonel can be used once a month or once a week, and then Reclast is once a year. Of these, the best data is with alendronate, Actonel, and zoledronic acid. So usually people recommend using one of these three agents because they have some effect on hip fracture reduction as well. The other set of agents is calcitonin, which pretty much nobody uses anymore. It does not really have much effect on the bones, can help a little with bone pain. So some people still use it maybe after a fracture for a little bit, but it's not hardly used at all. Then there's Prolia, which is denosumab, which you give at every 6 months. And that again acts in preventing bone resorption, just like the alendronate does, just at a different step in the pathway. Then you have Evista or raloxifene. You have the analogs of PTH, which is abaloparatide, which is Tymlos, which is given once a day. Teriparatide or Forteo, which is given at 20 micrograms once a day. Both of these are restricted to 2 years. because they don't work that well after 2 years, and they carry a warning about osteosarcoma in the bones, which they saw in rat studies. They haven't quite seen them in humans at all, but the warning is still there. So 2 years is what you give these for. And then romosozumab or Evenity, which is used for up to 1 year. It is a newer agent. It's given as 2 injections, 2 times sequentially once a month. So you can give that for up to 1 year. It helps to both build bone and prevent breakdown of bone. But after a year, it doesn't work. So that's about all you can use it for. So how do you start? Usually you start with either alendronate or risedronate. The choice of the bisphosphonate is basically any of these. They help reduce vertebral and hip fractures. Then most patients prefer the convenience of once a week regimen, but some people like once a year. So it's kind of, you discuss this with your patients, but alendronate is cheap, effective, and been around for a long time, so it's a good one to go for. So when do you use Prolia, which is a 6-month shot? Well, you can use it as an alternative first line to bisphosphonates if there's a contraindication to the bisphosphonates. For example, you have gastric contraindications. You can get, if they have a history of Barrett's esophagus or very severe reflux or other things that narrowing in the esophagus and gastric surgeries, things like that, then you might go for the Prolia. And you have to be careful if the people have chronic kidney disease, because you can use Prolia with chronic kidney disease up to kidney failure or stage 5. But if the GFR is less than 30, you want to evaluate them for chronic kidney disease related metabolic disease, bone disease first, or CKD, MBD, because there are many different types of this bone disease. That is best done by specialists. And the specialist of choice in that case is the nephrologist, because they should be treating their chronic kidney disease and helping figure out where the bone loss is coming from and what the ideal treatment would be. So sometimes if they have low turnover, then giving them a bisphosphonate can actually do them harm. So you do not want to treat people who have significantly low kidney function until you get some opinions from a nephrologist or have them see a specialist in kidney disease, ideally. How long should you treat? Well, with the Prolia, you want to treat it ideally lifelong if they're tolerating it, because when you stop Prolia, you kind of, they've seen that the increase occurs in the risk of multiple vertebral fractures, and that starts within 8 to 16 months after the last dose. So 2 months after they were due for the shot, if they missed it, the risk for multiple vertebral fractures starts to go up. And that's actually higher than before they started taking the denosumab. So you've got to keep that in mind. Now, in terms of fracture reduction, they have 12 years of data now showing it reduces fractures, so it's an effective agent. The important thing is patients have to realize that they're kind of committing to this long term. You could switch out after, if they, for some reason, they can't take it. You can change to another therapy, but how well that works is still open to question. So that's one thing to keep in mind when you treat them with Prolia. Raloxifene is it's a weak anti-resorptive. That's Evista. It can be used with osteoporosis if they have no history of fragility fractures, and they can tolerate bisphosphonates. They can tolerate Prolia, especially if they had a history of breast cancer. It might be somewhat useful. That being said, we don't end up using it that often at all. And then the newer agents are used when you have more bone loss. So severe osteoporosis, what is actually severe osteoporosis? If the T-score is less than -3, even in the absence of fractures, that's considered severe. Or if the T-score is less than or equal to -2.5 with a fragility fracture, that's considered severe. We have severe or multiple vertebral fractures. All those would be considered as severe osteoporosis. How would you treat severe osteoporosis? Well, you could use bisphosphonates or you could use anabolic agents. And that means you could use things like alendronate or Fosamax or Reclast, or you could use teriparatide, which is Forteo, or abaloparatide, Stimlos. You can also use as an alternative romosozumab, which is Evenity, once a month for up to 12 months. If you do treat with the anabolics, you don't treat them together with the bisphosphonates, but you treat them separately. After the time period for the anabolics is completed, you would start them on bisphosphonates or Prolia. The advantage of doing the anabolics is they build bone directly, and in the case of Evenity, it builds bone and prevents breakdown. So they're stronger agents. They'll build bone for a while, and then you have a higher baseline to start from, and then you prevent breakdown with using these anti-resorptors. I'm not going into that one. All right, case 4. So that's this another case on what would you tell a patient who's come to you with certain questions or certain issues. So she's 71 years old. She's on Fosamax for the last 3 years. Her recent bone density shows she has osteoporosis. L1 to L4 T-scores minus 2.5. She has osteopenia at the femoral neck with a T-score of minus 2.1. And compared to her last bone density, the bone density is improved significantly at the spine by 5% and significantly at the femoral neck by 4.8%. She doesn't have a history of fractures, and then she just saw Dr. Oz reruns, because that's what people do. And they said Fosamax will damage her jaw or cause her to break her femur. She wants to know if she should just stop her Fosamax. What do you tell her? Okay, we see this commonly. I'm sure all of you do too. Everybody's panicking about jaw pain right after they started Fosamax. What is actually the data on this? So one of the side effects, rare side effects of these bisphosphonates or Prolia or Evenity. So most of these agents, except Forteo or abaloparatide or Timlos, and except for those two, every other agent is known to be associated with osteonecrosis of the jaw, and that is breakdown in the jawbone. And so most cases of this have been seen in cancer patients who've had a compromised immune system. For example, people with multiple myeloma or metastatic breast cancer who were treated with high doses of IV bisphosphonates. But cases have been noticed in postmenopausal women who are taking oral bisphosphonates. What's the risk? 1 in 10,000 to 1 in 100,000 patient years in patients who are taking oral bisphosphonates. So if you take 1,000 of them and study them for 10 years, maybe one would get it. Or maybe if you took 10,000, maybe out of 10,000 in 10 years, one would get it. So it's pretty rare. What about atypical fractures? Now, these are again something that look very dramatic in slides. You'll see a slide where you have a clean break through and through the femur, or sometimes you can have smaller ones, but they don't show those in slides. But I didn't have a slide for you, sorry. But it's very rare again. The absolute risk is about 3.2 to 50 cases per 100,000 patient years, but that varies from study to study. Another study showed that there were about 1.74 fractures per 10,000 person year, so pretty close to what bisphosphonates show. And then, what the risk of osteonecrosis of the jaw is. Now, after 3 years of bisphosphonates in white American women, just another perspective, there were 149 hip fractures which were prevented, and there were 2 bisphosphonate-associated atypical fractures. In Asian women, the risk of atypical fractures is slightly higher, but again, even in that study, there were 91 hip fractures which were prevented using using bisphosphonates, and there were 8 atypical fractures. Even 8 is kind of high, but it depends on the population size. So far, I have had the good fortune of not running into any of these atypical fractures, but I've seen some osteonecrosis cases. So anyway, a reasonable approach to women with a low risk of fractures in the near future, like who have had stable bone density for a while, no previous vertebral fractures, they're not on glucocorticoids, then you can stop the bisphosphonate after 3 to 5 years and then follow the bone density and look at risk factor assessment over time. So that's to prevent all these. So how often do we check the bone density? every 2 years. If change in therapy is needed, we could do it every 1 year, but good luck getting Medicare to pay for that. Drug holidays, well, how long? So the bisphosphonates, there's a holiday recommended after taking this for about 5 years for the orals or 3 years for the IV bisphosphonates like reclass in patients who are at low risk. If they're at high risk, that means they have fragility fractures before or during treatment, or their T-score is below -3, you could continue the orals for up to 10 years or the IV for up to 6 years. So after they're done with that period, you want a 3 to 5 year holiday is supposed to be reasonable to and shows improvement. And if they saw improvement the last time, you can go back on the bisphosphonates at that point. There's no real solid data available on this for what the best approach should be, but that's kind of an expert recommendation. Like a 3 to 5 year holiday would be appropriate. In the case of Prolia, you don't do any drug holiday because you'll have a decline in bone density when you stop the medicine, plus the risk of vertebral fractures goes up. Okay, so what about dental procedures and bisphosphonates? So prior to starting any bisphosphonates, you do not need a dental exam. But if they were having an invasive procedure, for example, extractions, dental implants that are pending or in process, then you want to defer starting these until the procedures are completed. If they're already on bisphosphonates, then you can use the American Association of Oral and Maxillofacial Surgeons guidelines. Basically, if the surgery is not very invasive and they've been on the bisphosphonates for less than 4 years, they can continue and have whatever dentoalveolar surgery they need. But they suggest that you could stop the bisphosphonates for about 2 months prior to performing any dental surgery, which is very invasive, if they've been on it for more than 4 years, or they're also on steroids and taking the alendronate. So once the bone has healed, which could be a few months, then you can restart the bisphosphonates. So in other words, you could keep them on the bisphosphonates through their dental treatments as long as they are not in the process of getting it, then you don't start it. If they've been more than 4 years, then you do want to hold them for 2 months. How do you monitor your therapy for the bone density? Well, or the effect of your therapy for osteoporosis? Well, you do a bone density every 2 years. You continue the treatment if the bone density is stable or improved. So even if there's no change, that means you didn't lose bone, so you could still continue it. And now if there's a bone density decrease of more than -5% in 2 years, that's concerning. So you want to check if they're actually taking it. You check to make sure they don't have anything affecting the absorption. They didn't have gastric surgery or didn't develop a new gastric condition. That they're using calcium and vitamin D appropriately. And if there's something recent that happened, you may want to just look into secondary causes in case something new came up. But if it's more than a 5% loss and none of these hold, then you want to change their therapy. So how do you actually look at these bone densities? Well, when you compare bone densities, you want it to be looking at the same place done for comparison, preferably at the same machine, because each machine is different and has been standardized differently and even been standardized for the operators themselves. So you look at the alignment of the lumbar spine, you look at the rotation of the hip, and each time they do it, they kind of try to do it exactly the same way. The area compared should be comparable to the last time. So it's very important that they highlight the same part of the femur, for example, and compare the exact same part, or you can end up with all kinds of changes that are not real. And then you look for artifacts, for example, osteophytes or arthritic changes, which can increase bone density. So somebody with severe arthritis in the spine can have a bone density that looks completely normal, yet they've had compression fractures, so they do have osteoporosis. Here's some examples of artifacts. This is an 18-year-old girl with anorexia, and she did a DEXA, and then, it looked pretty good. The Z-score was 1.6, and then they saw this little shiny object there, and that was her belly ring. And once they took that out, the T-score went from -1.7 to -3 at the lumbar spine, and so it's basically causing an artifact here. It's another artifact example. You've got some end plate sclerosis at L4, L5 because of chronic changes. Okay, what happens is, as you can see, the T-score is showing osteopenia at L1, L2, and L3, and then L4 is minus 0.1 because of all the sclerosis here, which you can see more clearly on the X-ray. So it's making the entire bone look thicker than it is. Here's another artifact that's calcification of the longitudinal ligament or interspinous ligament. It's also called dagger spine. And you see the T-scores here are very high. This patient could have osteopenia or osteoporosis, but you can't tell. So here's just a real quick case on somebody who had an artifact on the bone density. So she was 89 years old. She came in for a routine checkup. No history of fractures or falls. Has occasional back pain. She's been getting calcium and vitamin D. Her exam is basically unremarkable. Breast exam is normal. Lab show normal calcium, kidney tests, vitamin D, PTH, CBC, protein electrophoresis. And so they did a bone density after that. Here's the bone density. Okay, so you see, if you look at L1 to L4, L1's T-score is 2.5, and the others show some minus 0.1, minus 0.5, minus 0.9. So overall, it's 0.1 is the T-score. So is this a normal bone density? The Z-score, if you look at it, it's a little above, between 2 and 5, averaging to about 3. Something is a little off here. So the bone density showed here that the T-scores are relatively normal, and then the Z-scores are relatively high. So they looked at the lateral lumbar radiograph here. If you look here, that's L1 looked at laterally. It doesn't quite look like L2, L3, and L4. In fact, there's a fracture going across here. And they did and looking at it laterally, what you see is this bunch of calcium sitting in front here, which actually turns out to be a calcified aorta. So when you look at it with the VFA, remember I said that won't be covered, but that's your lateral DEXA. You can see that's L1, and it's all thickened here, and there you can see the fracture through it. There's L2 to L4, and now the bone density changes dramatically. You've got a T-score between -2 and -4.3, averaging to -3.6, so she has osteoporosis. She doesn't have a normal bone density. So there's clear artifact here from the calcified aorta and from that vertebral fracture. So always keep these things in mind. If you can, look at the image, try to see what's actually going on with this patient. And so there just tells you what the diagnosis was. And so you keep vascular calcifications in mind, you keep compression fractures in mind, which are common. If you see, try to look at the bone density report. If you see that there's 4 different bone densities for L1 through L4, look at the report, see, hey, what's going on? It could be 1 or 2 have fractures, could be there's arthritis there, it could be they had surgery to one of them. So all of those things can interfere with the bone density interpretation. And it may look normal, but it's not. So these are just some things to watch for. When you compare the bone density, make sure you're using the same machine, because the same region of interest, same reference database, because each machine and each center is classified based on these different databases which are very localized. So you don't want to send somebody for 2 bone densities at 2 different places, because you'll get 2 different results and you can't compare them. You look at the least significant change for a DEXA machine. This is done by comparing the absolute bone density, which is those 0.882 or 0.714 you might see. Those are, they actually subtract those things and look at the change. You don't compare like a T-score of -1.5 with -1.3 and say, hey, this is great, it's working. You have to look at the absolute change. And then if the calculated change in bone density as compared to the previous is greater than the least significant change, then the change is significant. That's why they have those stars on those bone density reports where you see oh, is this a significant change or is it a non-significant change? Because it varies by the machine, but when it says it's a significant change, that means statistically it's matching the database and it's showing a significance in terms of a change. Otherwise, it could be a -3% and it's not significant. It's within the error of the machine. All right, I guess that's all I got to say. So thank you for your attention. And that's just the patient going to her doctor and saying, hey, I risk jaw death and cancer, but my bones might be strengthened. When the drug works, yeah. Okay, so.
we have one question
Yeah, sure.
for you. It said, if you stop Prolia, can you use another agent such as Reclast? I think you said something about switching or not switching. They didn't hear that clearly.
Yeah.
They have some patients that with perceived side effects from Prolia, so wanted to know what to do with them.
Yeah, that is, data-wise, that's not very clear. I mean, the experts, when you ask them, say, well, yeah, you should change it to something else. They don't really have studies to show what that something else should be, whether that should be an anabolic, whether that should be Reclast, whether that should be alendronate. So they recommend trying to go with a bisphosphonate if you can. We don't really know the answer as to whether that'll actually prevent further bone loss or help with the bone density or not. So something to keep in mind. We don't have the answer, bottom line.
One more question just came in. Wondered about your opinion about what treatment has the best long-term outcomes.
Okay. It's long-term kind of depends. I mean, I guess there's no clear answer for that. So short-term, yes, the anabolics worked well. If you're looking at bone density itself, the Evenity seems to be showing very strong effects in terms of helping the bone density. It might be the strongest because preventing osteoporosis by preventing bone resorption and causing bone, anabolically helping bone build up. But you can only use it for a year because it doesn't work after a year. The Forteo or the abaloparatide, those help to build bone and will add a bunch of bone to the spine, but after 2 years, their efficacy decreases, and they're not recommended beyond 2 years because of those rat studies, which hopefully someday that warning will go off. But whether that'll change their efficacy after 2 years, so far that's not clear. So it depends on the setting. I guess you use it if somebody's had a recent fracture or their bone density is very low, going with a anabolic like Reclast or not Reclast, with the Forteo or Timlos, which are the daily shots, or going with the Evenity for a year, will help to build bone quickly. So you get a little bit of a jump, and then you switch to the bisphosphonates, which would be a reasonable choice to do. Prolia is a second option, that depending on where the kidney function and gastric side effects are.
Great, thanks.
Sure.
That's all the questions.
Wonderful. All righty. Well, thank you, everyone.
And if you would hit escape on the keyboard.
Keyboard off.
There you go.
Yeah. Okay. Strange talking to an empty room. Was it okay?
It's different, isn't it?
Yeah.
Good job.
That was okay.
It was good.
So how do you move forward?
If you.
With the left button?
Yes. Yeah, you want the mouse and down in the bottom tray.
This is this. This is forward.
This is forward?
Yeah.
Okay.
And then this is the mouse.
If
So
you use the
got
mouse
to-
down in the bottom tray, hit the
Yeah,
PowerPoint.
there. Yeah.
Yep.
Here. Just hit that, and then you can open yours.
And if you go to the very top, yep.
There.
All right.
Beautiful. Good.
So yes, it is a very interesting experience to be talking to an empty room. I suddenly have a lot of appreciation for all the, CBO members who are doing shareholder meetings to an empty room all the time. My name is Tarang Sharma. I am an endocrinologist and I'm embedded with Vestival Internal Medicine here in Vestival. And I will be telling you all about diabetes today. It's like bottling an ocean into a bottle, and I'm going to do that magically in 30 minutes. Okay, Romy, I think I did the same thing you did.
Yeah. Go the other way. Go the.
Oh, go the other way.
Yeah. Yeah. Oh, no. You
No,
did the
nothing
other one.
happened.
Yeah, I did that. Let me see if I.
Slideshow
This
again.
slideshow again, and then it's.
This one,
Yeah,
right?
this one, yeah. No. Sorry, my bad. Sorry. It's
Oh, this one.
Yeah. Sorry, that's my bad.
Ah, all right. So, what questions are we trying to answer today? I do like to focus on how we got where we got. And so, question is, what have we learned in the last 100 years? I think it's more important to me because this is the year, 100 years ago, that insulin was discovered. I love to spend time on those things, and I will today since I'm getting a chance to. How was all this journey in the last 100 years relevant for management strategies today? Why do we need newer agents? And then, with all these new agents out, how do we drive these algorithms and put it all together? So 1921, 100 years ago, it was a start of sorts. I have a picture of 4 people up there. It's Banting, MacLeod, Best, and Collip. These were 4 people who were instrumental in discovering insulin in Toronto in 1921, about the summer of 1921. So 100 years ago, around this time, insulin had already been discovered. It just had not been injected into a human yet. But it's an interesting piece. It's all over on Google if you search for it. And if somebody's interested, you can actually look. These are actual writings of the product called Ileton that was isolated from dogs that was given to a diabetic dog to see if you could lower their serum glucose every hour, and it did. This is the first record of actually something being isolated that lowered glucose consistently, and that was the discovery of insulin.
I don't think
So fine, we discover insulin.
I think they're giving it.
Then what happens in the first 50 years, I broke it up like that because in the first 50 years, you turned an acutely fatal illness to a chronic illness. That's what you managed to do with discovery of insulin. Back in the 1920s and before, when people were diagnosed with diabetes, most of them used to die in a period of 3 to 5 years. But with discovery of insulin, just the single discovery of one agent, people started to live longer. So in January 1922, the first human, Leonard Thompson, he received insulin. Then, the Nobel Prize gets awarded to Banting and MacLeod. There is a huge argument. That's another story. One day I will tell you that too. And then in the 1930s, long-acting protamine and zinc insulins are introduced. Remember, they are still pork and beef insulins, but they are NPH and Lente insulin that was sold in those days. 1940s, we get a dedicated insulin syringe. Then Mr. Sanger, he's a famous biochemist, isolated lots of structures of hormones, and he determined the structure of insulin, which then became important in producing human insulin down the road. In 1956, tolbutamide was introduced. I don't know how many people here even remember what tolbutamide was. It was the daddy of sulfonylureas, right here. So introduced in 56. Metformin was introduced in the rest of the world around this time in 1957. It did not come to the United States in the first 50 years, though. And then in 1965, we first got dextrosticks. Before that, there was no easy way to check blood sugars. Dextrosticks was a color strip that people would then match to see what the range of their sugars was. Very crude, very preliminary, very rudimentary, but all these discoveries, they did lead to people surviving longer. And so finally, you've turned a acutely fatal illness into a chronic illness. Now you've got to deal with it. You have to figure out what to do with that chronicity and what problems that chronicity causes. So now, from 72 to the end of 20th century, we start to refine things a little bit. We first get this Ames reflectance meter. It used to be as big as a transistor, which again, I don't know how many people remember what transistors were. But eventually, like everything, like every device, the gadgets became smaller and nicer. A1C, 1977, this, whatever, the metric that we like to follow all the time, that's like the gospel of truth. This was introduced in 1977, so in most of the lifetimes of most of us practicing today. More interest over here. Human insulin came in 1982. FDA did not bless metformin in United States until 1995. So we haven't really had it for that long in United States, even though nothing starts on any algorithm without metformin being in place first. Lispro introduced in 1996. So 1990s are seeing some progress happening. And then I will add this rosiglitazone, which is not marketed anymore. Avandia was introduced in 1999. But key thing over here is towards the turn of the end of 20th century, these two trials came out, DCCT and UKPDS. I'm not going to show the actual trials, but basically the idea here is these were the two trials, very well conducted trials, long-term prospective case controls, prospective randomized trials. These are the trials that first showed that tight control matters. You reduce chronic complications by about 50 to 70% when you control people well, but it also showed that people, they have a greater propensity to hypoglycemia. And this is the world we live in today. Our current faces, we want tight control, but we don't want low sugars. In order to have tight control, we do not want cumbersome regimens because it reduces compliance. How are you going to even monitor whether they're doing well? So you want sensitive monitoring. And then lately, over the last 10 years, there is this increasing push for, do the drugs have cardiac benefits, renal benefits, weight benefits? What is the durability of the regimen? It's not just about let's add an agent until it fails and then add a second agent. No, you want to harness every possible mechanism of the disease to try and see if you can come up with a regimen that is going to last the patient for a while. And finally, cost is a major factor these days. So now that we have a current face of diabetes and we kind of know how we got here, I'm going to give you 5 pearls today. Pearls are shorter, some require more slides, but I'll go over them. Pearl number 1, type 2 diabetes, which is the main crux that we are talking about today. Type 2 diabetes is a progressive disease. And eventually most patients will need insulin therapy. It is paramount for the patients and their doctors, whether it is their primary care physicians or any other doctor for that matter, to understand this. This is a chronic disease that the patient will carry the burden of for the rest of their life. They need to be validated for the efforts they make. They need to understand at the outset that just because they are doing the best job they can doesn't mean medications will never increase. They probably will. You buy a good car, it still gets old. And this is kind of like that. Why does diabetes progress? Well, in type 1 diabetes, it has already progressed by the time it presents. But in type 2 diabetes, what plateaus is insulin resistance and hepatic glucose production. But what doesn't plateau is gradual beta cell failure. So beta cells, they sequentially fail as people age with diabetes. And as you manage their diabetes better and better and better and better, and they live longer, you will see this happening. And so most of the time, majority of the patients will require more insulin, more medications, including insulin. And it is something that needs to be somehow conveyed to the patients every time or nearly every time they come for office visits. It helps prepare them for future. Pearl number 2, try and mimic physiology for appropriate glucose control. Again, we used to have this sequence, use agent 1, and if it fails, use agent 2. And then if it fails, use agent 3. Back then, we honestly didn't have too many agents. But still, the whole idea of using one agent until it fails is not correct. And we want to mimic physiology. This is a busy physiology, but this is a very famous lecture that was first delivered by Dr. Ralph DeFranzo as a Banting lecture in the ADA about 10 years ago. Traditionally, back in the 80s, 90s, when a lot of us went to medical school, our traditional teaching was it's a triumvirate of problems. you have problems with insulin secretion, hepatic glucose production, and then tissue uptake of glucose. Over time, we have realized nearly every organ is involved in diabetes, and every organ must be addressed when you're trying to address diabetes management. That is famously called the ominous octet by Dr. DeFranzo. I wanted to put up the slide there just as a reminder to people that there are multiple mechanisms and they all must be addressed to come up with a durable regimen. Similarly, when you are trying to mimic insulin physiology, you want to mimic physiology. We know people are not secreting insulin in the same amount all the time. When they are fasting, they are secreting less, but they are still secreting some. And when they're eating, they're getting these sharp bolus spikes, and those are your bolus insulin spikes. And it's important to remember those things. And I'll put it all together in another pearl for you. This is the pearl that's going to be the longest one. And remember, there is a pearl number 4 and pearl number 5 after that, so save your energies. Pearl number 3, treat the patient, not just the numbers. I don't know, I understand everybody in primary care is very overwhelmed, but it is important for patients to have that connection, because without that, they will not listen to anything. If we keep focusing on their A1C and we do not tell them what that A1C means, because we are asking them to check their blood sugars. They don't understand the link between their A1C and their blood sugars. They also don't understand the link between their juice and soda and their sugars. That little thing, if it can be explained one time to the patients, they will appreciate it. If we can explain why are we trying to control their blood sugars instead of that being their report card, they will appreciate that. We may get just a little bit more compliance out of them when we are approaching their problem in this way. So goals of therapy would be determined by the patient, individualized therapy. We want to prevent long-term complications. We want to minimize short-term complications. We want the regimen to be affordable, which is all very good. So an older patient, much older patient, whose life expectancy may be low, we may be more interested in minimizing his short-term complications. Somebody who's young and otherwise healthy, long-term complications may be more important for them. That doesn't mean that they should be having hypoglycemia, but at the same time, we can focus on tightening their control to focus a little bit better on preventing long-term complications for them. Affordability is a big one. I think all of us as endocrinologists, many times these days, a lot of us get a lot of patients where the sugars are out of control because whatever regimens are being tried, the patients are not adhering to them. And if you ask them closely, most of the time, the insurance coverage is bad. And if the insurance coverage is particularly bad and persistently bad, there is no point in persisting with a regimen that is fundamentally good but completely unaffordable. They have to be tried on other agents. So you want regimens that are individualized to the patient. You want to try and come up with regimens that are relatively convenient and flexible so that they can be compliant with those. And then one thing that every patient needs to understand, you want to treat to prevent high blood sugars from occurring, not to bring them down. That is a key thing that patients, maybe they understand, but that needs to be emphasized to them. We are not trying to bring sugars down and make them better. We are trying to prevent them from rising. And then lastly, we never ever want to come across as if we are threatening patients with insulin. Remember, I said it's a progressive disease. Most people will eventually need insulin in some form or shape. They need to consider insulin as their ally and friend and not as their enemy. And the tone of all our conversations should be appropriately modified. So we do not say, if you don't this, I will put you on insulin. In the end, insulin will fail too if they don't do what they should be doing. So what are our current approaches? Lots. And I'm not going to go through each one of them today. I highlighted SGLT2 inhibitors and I put 3 stars over there because I will spend a few minutes on those. Because in the last year or two, there is a lot of noise around these agents. GLP-1 analogs, DPP-4 inhibitors, amylin analogs, dopamine agonists, insulin. We have newer profiles, we have delivery devices, inhaled insulin. All these options have exploded in the last 20 years. SGLT2 inhibitors, what are these? By name, Invokana, Farxiga, Jardiance. There is a fourth one called Steglatro. I don't come across it that much, but I put up the names over there for familiarity. What do these agents do? They allow renal elimination of glucose with osmotic diuresis. I think most of us know that. What are the benefits? You get very robust A1C reductions of more than 1% usually without hypoglycemia because the renal threshold is also glucose dependent. You get cardiac and renal benefits these days, which I'm going to show you a couple of slides on. And then, so when are you favoring these agents? Lately, you're favoring them a lot. You are favoring them in patients who have cardiac and renal problems. You are favoring them in patients who are at risk for cardiac and renal problems. And I would suggest that's something that I threw in there, that you are favoring those over some other agents, especially GLP-1 analogs, in patients where metabolic challenges are less profound. Let's say this is a person who's not profoundly obese. A huge appetite is not his problem. He's relatively leaner, maybe a little overweight, but you don't perceive that his driving problem is just bad raging metabolic syndrome. You may favor these agents over GLP-1 analogs in some of these patients. When not to favor patients with severe hyperglycemia, that is not the time to put them on these agents. The glycosuria will be very, very severe. And because of that, their chances of UTIs and yeast infections would be higher. Chances of dehydration would be higher because you're causing very severe osmotic diuresis. People who are very prone to genitourinary infections, if you cannot prevent them in any way, then yes, perhaps these are not the good agents for them. Although I will tell you, the push, like I said, is great for these agents right now. So this is the study on dapagliflozin, which is Farxiga, that came out in October 2020, so a little over a year ago in New England Journal of Medicine. And I want to tell you a little bit about this study. So the trial, it was in patients with CKD with or without type 2 diabetes. We've had several trials. There have been trials on patients with diabetic kidney disease. This one is a trial on patients with or without diabetic kidney disease. They all had proteinuria though. And then they gave Farxiga or dapagliflozin to these patients. And then they looked at primary composite outcomes, that usual standard ones, decline in GFR of 50%, end-stage kidney disease progression, or death from renal or cardiovascular causes. What did they see? All I want to show you here is the separation and the degree of separation in these lines, no matter how you look at it, whether it's a primary composite outcome, renal specific outcome, death from any cause. Literally, I don't know if people can appreciate the color. This is in red, which is placebo. This is in blue. This is dapagliflozin. And no matter where you look at it, there is an immense separation in all these lines, literally after 2 to 4 months of therapy, and it continues. So this trial was brought to early stop because it was felt it was unethical to not offer dapagliflozin to the placebo group. And then these findings were published in October of 2020. So what is the impact of this trial? This is the DAPA-CKD trial in between. I will say I borrowed this slide from another presentation from another endocrinology nephrologist from CEU because I really liked it. Unfortunately, I think I borrowed his checkboxes too. But basically, this DAPA-CKD trial, it was conducted on about 4,000 patients. They had CKD. GFR was actually low, 25 to 75. Most of the time, the package insert for dapagliflozin says GFR less than 45, not recommended. But here they pushed it. They gave it to more people with or without diabetes, and they saw a 40% risk reduction. This was the trial a couple years ago, that was in diabetic kidney disease that was released by canagliflozin, which is Invokana, and similar reductions here. So these guys, our dapagliflozin guys right now were a little bit bolder. They said, all right, we'll do this for people without diabetes. Let's see what happens. We'll push the GFR from 30 down to 25. Let's see what happens. And they saw a risk factor reduction here too. They're doing such a study with Jardiance also, supposed to be released sometime next year. Even more, the GFR is even more loose, I would say. They are including a lot more people with kidney disease, and we'll wait to see what those outcomes are. But these are practice-changing publications, so to speak, that the thought is that this category of medicines, far from causing kidney damage, it probably retards kidney failure and progression of kidney disease in some way. The thought is maybe it does that by changing the sodium transport through the kidney tubule, because SGLT2, it attacks the sodium and glucose co-transport. But the exact mechanism is not known. But there are now 2 studies that are showing that there is significant decline in progression of kidney disease in patients who are on these agents. So the recommendation for these have become easier and looser. Hold that thought, because I'm going to put it all together once I go over these other agents very quickly. GLP-1 analogs, I would say they are one of my favorite agents, and many of us use them very freely. GLP-1 analogs, Byetta was the first one, also called exenatide, now marketed as extended release exenatide or Bydureon. The daily injection Victoza, already old it seems in the last 10 years, because most people are on once weekly Bydureon, Trulicity, or Ozempic. Ozempic is semaglutide, also marketed now orally as oral Rybelsus. What are these agents all about? These cause glucose-dependent insulin release and glucagon suppression. They cause greater than 1% suppression in A1C, also very robust agents. They don't cause hypoglycemia, again, because the mechanism is glucose-dependent. They cause weight loss. They have cardiac benefits. And so these are good agents to favor in patients who have cardiac problems, who are metabolically challenged, because they cause some weight loss and appetite reduction as well. And they are the only agents that actually address glucagon. So in that sense, they are very good to use. When do you not give these agents? Most of us know this. Pancreatitis, it's a black box warning. People with medullary thyroid cancers, that is a black box warning. And then people with very severe existing gastroparesis and GI issues, perhaps they are not the best candidates for it. It's not an absolute contraindication in those people, but they don't do well on it. So, and DPP4 inhibitors, they are in the same pathway, incretin pathway, just like GLP-1 analogs. They are weaker agents. I usually find less use for them in my practice, because it's very uncommon for me to want to push their A1C down just by 0.5%. But they have a place sometimes in people who have renal problems, who genuinely need just a little small push in their glycemic control. I put all these as honorable mentions. We will have another day and time to talk about them. Dopamine agonist, cycloset, amylin analogs. I have not been using them for many years. It's called Simlin. Colevasalam, Velcol. It overlaps with benefits in cholesterol. It's basically marketed as a cholesterol medication. And then this inhaled insulin, also called Afrezza. The important thing, it's short-acting insulin, and the inhaler is cute compared to the Exubera inhaler that came out 10, 15 years ago. Insulins, we have better insulins these days. We have flatter basal insulin and we have sharper prandial insulins. And the only thing in this slide that I want you to look at is this little red. This is what NPH used to be like, hardly flat. Then we marketed Lantus, this dark blue, which we said was very flat. It isn't that flat, but definitely much flatter than this red NPH. Now we have Toujeo, which is concentrated glargine, or Lantus, concentrated glargine. And then we have Tresiba, which is Degludec, which are much, much, much flatter. Where is my arrow? These green ones. So much flatter profiles. This light blue one is Levemir or Detamir. Not too, it's kind of sits in between NPH and Lantus. And then, so Toujeo and Tresiba or Glargine U300 and Degludec, definitely flatter profiles. You don't have to race after the profile of the insulin. The profile of the insulin matches physiology better. And then rapid ultra-acting insulins, we are all familiar with Humalog and Novolog. That is this line over here. And then fast-acting Humalog and fast-acting Novolog. That is marketed now as Lungev and Fiasp. That's these lines over here. This at the bottom is 1 hour. And if you look at the first 15 minutes, the amount of insulin that gets into the system with the ultra fast acting is nearly 2 times what Novolog and Humalog do. So that fast action matters to a lot of patients who feel that insulin doesn't work fast enough. Remember regular insulin that used to be used before Novolog and Humalog came around, that used to have an onset of action of 30 to 45 minutes. So we have come pretty far since then. And then we have all these insulin delivery devices. I just wanted you to be aware of them. You will hear from patients about them. Smart pens, which allow people to interact with the pen through an app. They are not able to dose through the app, but they're able to record their data. They're able to record that insulin was actually taken. So people with memory issues sometimes are helped with that. People who are using bolus wizards, you can feed the bolus wizards into their apps. So these, InPen is being marketed by Medtronic, and you will hear these names from people sometimes. And then augmented insulin delivery devices where you have a pump that is delivering insulin in response to what a continuous glucose monitor is sensing the sugar to be. These are hybrid models. They are partly automated. Patient still has to drive boluses, but these exist. So we have all these gadgets and we have all these medications to control our sugars. And so what are we saying? We are saying try and use physiology. If you are using basal insulin, please don't over-basalize. I remember 20 years ago when Glargine or Lantus first came on the market, we were teaching people not to use sliding scales, but to use basal insulin instead. So now we on the other route, we are giving too much basal insulin. If you can see this shadowed area, this is what, let's say you're giving too much basal insulin. What will this patient have? He doesn't need this much insulin when he's sleeping. He's going to have nighttime lows. He's still going to have mealtime highs because he doesn't have enough insulin there. And then middle of the day, he'll love it. He's going to snack all the time and eat all the time because sugars are dropping. So you will reduce their A1C because you're going to have low blood sugars all over the place, but he's not going to be very well controlled. His sugars will be a mix of highs and lows. So what should we do instead? You can either use basal bolus insulin, or you can use a combination of basal insulin when you're using basal insulin and use some oral hypoglycemics and GLP-1 agonists to help this patient out. This is a very busy looking slide, but this is it when it comes to the ADA algorithm for diabetes management. I wanted to show you how this bifurcates now. So it bifurcates, I would say, into major arms. You first say, fine, metformin and lifestyle changes. Yes, that is your cornerstone. Even more than metformin, I'd say lifestyle changes. I tell every patient, if you cannot do what even a little bit of, if you cannot meet me even halfway, then diabetes cannot be managed with anything, including insulin. So you've done the first line thing. And then after that, how do you decide on what to do next for this patient will depend on, you will first assess if the patient has any existing cardiac disease or any renal disease. If they do, your pathway will go down this way. And if you can read the fine print, or if you go online and look at the actual algorithm, it is all about SGLT2 inhibitors and GLP-1 analogs, especially SGLT2 inhibitors when it comes to presence of CKD. So right off the bat, after metformin, we are choosing to use these agents and not sulfonylureas if we can help it in patients who have existing cardiac or renal disease. If they don't have that, then you can think on further lines. Is the patient at very high risk of hypoglycemia? Older patients, debilitated patients, patients eating very erratically, patients with very severe liver disorders, kidney disorders, they are all at risk for hypoglycemia. Again, you may not be interested in using sulfonylureas for them and subjecting them to a lot of hypoglycemia. You may not be interested in using large doses of long-acting insulin just to damp everything. You would try and be intelligent and harness all these other agents, and ADA now doesn't make any distinction between what you want to choose. You can use lots of agents as your second and third agents in whatever sequence you like, depending upon which patient you have in front of you. So if so do they have heart disease and kidney problems? Do they have very high risk of hypoglycemia? I like to call this one, are they metabolically challenged? If they are very metabolically challenged, then yes, perhaps GLP-1 analogs would be important to favor. Could you add SGLT2 inhibitors there first? Absolutely. And a lot of times we are using both these agents together. They work very well together. Last of all, at least there is recognition that cost is an issue, and this is the only algorithm where sulfonylureas and TZDs, they are at the top of your algorithm. Everywhere else, they are at the bottom of the totem pole. All right, so that was a long pearl number 3. Pearl number 4. A1C obviously is not the entire story. A1C can be faulty. People can be hypoglycemic, can be compulsively eating. You will make their A1C look good because the averages will be good. They can be on iron therapies, erythropoietin, transfusions. They may be just anemic. Glycated hemoglobin will not be accurate. You're assuming that the RBC turnover is 120 days, and you are assuming a steady state of affairs. If that is not true, if they are anemic, if RBC lifespan is shortened or elongated, or if they have hemoglobinopathies that they are not able to glycate well, or you can't even measure that specific hemoglobin well, their A1C is going to be faulty. So A1C doesn't tell you the whole story. Finger sticks also don't always tell you the whole story, though they tell you many. Here is a patient. These 3 arrows are telling me patient A, patient B, they're measuring their sugars 3 times a day. All 3 blood sugars, they look good. But patient A has fewer excursions into the highs and lows. Patient B has a lot of excursions into the highs and lows. Ergo, even though their finger sticks may match, their A1Cs may be similar because law of averages, the control of person in the blue is better than person in the red. How do you sometimes unmask these things? By these things called continuous glucose monitors. All of us are probably very familiar with Libre and Libre 2 these days. These are the cheapest of the lot. Dexcom and Medtronic are definitely more expensive, and they are not for everybody. Libre 2 acceptance and Libre acceptance has been excellent. They are a little challenging for patients to get through their insurances sometimes, but many of them are willing to get them out of pocket because they are not that unaffordable. So I feel it's a good idea to offer these to people. When will these things become standard of care? I do not yet know. Pearl number 5. This was my last pearl, and I really wanted to include this here. I think it's important for us as physicians to know at least some basics about what constitutes a diabetic diet and to give patients some specifics. I've alluded to a little bit of it before also. It doesn't help for patients to hear drink less soda. It doesn't help them to hear eat less rice. What helps them is to hear how much does a can of soda raise my sugar. If you tell them that 1/3 cup of juice can raise their sugars by 50 or 60 points, all of a sudden that probably makes some sense to them because they're checking their blood sugars. If you tell them that every 30-point rise in blood sugar changes their A1C by 1%, now they can put it together. Oh, I just increased my A1C by 2% just by drinking this half a cup of juice. Yeah, you did. And sometimes these little things that you don't have to memorize everything that exists out there, neither does the patient. But knowing a few of these things and giving them in little snippets to patients here and there does help. So at the end of it all, we want to know why to treat diabetes. We want to use that to define goals of treatment. We want to utilize strategies that will mimic physiology so they can have a regimen that is long-term and lasting as long as possible for them. You want to treat to keep sugars within a narrow range. And then, as and when the need arises, you want to address disorders that are typically associated with diabetes. That's all I had today. Thank you.
Thank you, and I don't have any questions. Want to thank you both for the discussions tonight. Appreciate it very much.
Thank you.